All right, now we get to look at malrotation and different weird things that happen to the small bowel. So let's start off with something kind of obvious, I think. When you look at the small bowel, the first thing you notice is this is really not symmetrical, right? The small bowel is really mostly on the right side of the abdomen. The ligament of Treitz is up here in the right upper quadrant, and the terminal ileum is down here. So left upper quadrant, and the ileum is down here in the right lower quadrant. So when I think about and teach rotation and malrotation, think about development by beginning with the end in mind. So the appendix is in the right lower quadrant, ligament of Treitz in left upper quadrant. How did they get there? Well, this is going to be really in about week 6, we're going to start seeing what's happening. And the key is the rotation. So the ileum grows faster than the rest of the intestine and buckles out into the intestinal cord, creating what's called the primary intestinal loop. So it's herniating out into the umbilical cord in week 6. And you get this. So this will be out in the umbilical cord here. In this diagram, the proximal end is going to be the ileum. The distal end is the cecum. And you can see there's a little appendix to orient you. We'll come back to this later. And the apex is the vitelline duct, or umbilical mesenteric duct. And the first rotation is 90 degrees counterclockwise as the bowel herniates into the umbilical cord. Now, all of this counterclockwise, 90 degrees, 180, it's like, what are you talking about? It's very 3D, very difficult sometimes to imagine, but I'm gonna get there in a minute and give you an easy way to do it. So hang tight. So again, 90 degrees counterclockwise, and there's all these words, and I'll get you these slides to make sure that you have these, and you're going to have these in other forms too. I know from Dr. Hill and everyone else. But what happens next? So you have this plain loop, goes out into the umbilical cord and rotates 90 degrees. And then in the 10th and 11th week, it returns to the abdomen with a second rotation that's counterclockwise, an additional 180. Now here's where I'm going to try to make it easy for you. I kind of call this Tai Chi. If you've seen Tai Chi, it's a lot of very smooth motions. So here's what I want you to do. I want you to take your right hand, point it with the thumb down, okay? And your thumb is your appendix. The little finger side of your arm is the top of your loop. The vitelline duct will be right about here. Here's the bottom side of the loop, and your thumb is the appendix, okay? So you're gonna go straight out away from your body with the thumb down, and as you do it, you're gonna rotate 90 degrees. So now the thumb is to the left. That's bowel out of the abdomen. And then for the bowel to come back into the abdomen, flip your hand so that your palm is pointing up, and your thumb is now to the right as it's coming back in. Let me see if I can give you a little better view here. So in this Tai Chi move. So you go out of the abdomen, 90 degree rotation, thumbs to the left, back into the abdomen, another 180 degrees to the right. So your thumbs to the right. And now guess what? Your appendix is on the right, where it should be. Again, bowel returning to abdomen, I think is what I would name it. So here's the pictures again. So here's the 180 degrees returning to the abdomen. And then just a little more to get everything completely in place where it should be. So that the appendix and cecum is a little more inferior. Now I'm not gonna play this. This is a video, but I will send you a link to it because it's a pretty good one. Now, just like everything else we've been teaching, right? You have steps. It's got to rotate 90 degrees. It's got to rotate 180. It's got to come in. It's got to come out. It's got to fix down. What could go wrong? So the 3 stages, if you will, stage 1 is the herniation out of the abdomen. Stage 2 is return. And stage 3 is fixation, where it's supposed to be. So let's look at what could go wrong in each of those stages. So failure to progress to stage 2, so the rotation would return to the abdomen, is an omphalocele. And you can see here is the bowel and probably a little liver in this case, out of the abdomen in the umbilical cord. This is another good example of what it might look like. So this occurs early in development, right? Weeks 6 to 10. Syndromes and other associated defects are common. About 20% of these babies have congenital heart disease. About 20% have syndromes. There is a different kind of abdominal wall defect, different from an omphalocele, that's called a gastroschisis that looks like this. This happens later in development, and syndromes and other associated defects are very rare. There can be small bowel atresia, so failure of the small bowel to completely form, because this is herniating out of a little defect on the abdominal wall just to the side of the umbilicus. And that's almost acting like a constricting rubber band in terms of the blood flow to the intestine. And so they can develop atresia from that. So again, abdominal wall defects, 2 kinds. Omphalocele, the defects through the umbilical cord. It's usually got an amniotic covering over the intestines, and associated anomalies are common. Gastroschisis is a defect lateral to the umbilical cord. Just trivia, it's usually on the right side. There's no covering. There's about a 17% of atresia, but other associated anomalies are really rare. So stage 2, return of the bowel to the abdomen with that additional rotation. So failure to completely rotate is common. And basically there's 2 major clinical forms, if you will. So in embryology, when something has an arc like that, it can basically stop anywhere on the arc. So people will say 90 degrees instead of 180 degrees, but it's more likely to be 172 degrees or 190 degrees. So again, it's understanding the process helps you unravel what the anomaly is when you're actually looking at the baby. So if you have the primary intestinal loop that goes out and just comes straight back in, we call that non-rotation. Okay. If it goes 180 degrees, so when it comes, so you could do the 90 degrees out into the bowel, but instead of doing the complete 180 over, it stops kind of up at the top or somewhere in this part. We call that malrotation. That's clinical malrotation. And I know it doesn't make sense because all of this should be malrotation, but this is the classic clinical form that we call malrotation. So the primary loop has gone out into the umbilical cord. It has come back in, but instead of making the full 180-degree loop, it's gotten stuck somewhere in the top. So again, non-rotation, that initial, just the primary loop out and back in, looks like the primary intestinal loop. All of the small bowel is on the right side of the abdomen. All the colon is on the left. This doesn't need any surgical repair. It doesn't need anything done. It's usually asymptomatic and there's not much danger to this. That's different than what we call malrotation. So again, imagine if your appendix, comes out, rotates, and then comes back in and stops at the top instead of going over to the right side. It's now going to be in the upper abdomen. The colon, if you will, is programmed to fix itself down to the lateral wall of the abdomen. So it puts out these bands, like it's supposed to, that are called Ladd's bands. And you can see they are crossing the duodenum. And therefore, they can cause duodenal obstruction. But this one's dangerous. So why is it dangerous? So imagine a normal mesentery. So all of the blood vessels, so your arm is the superior mesenteric artery. All of your fingers are the blood vessels going out to the intestines here at the tip of your fingers. And normally, and do this on yourself, your little finger would be fixed down on the right lower quadrant. Your thumb would be on the left upper quadrant where the ligament of Treitz and the terminal ileum are fixed down. And it's not going anywhere. It's not moving, right? If this bowel comes back into the abdomen without those points of fixation at the ligament of Treitz and the terminal ileum, what ends up happening is it's like a fist. It looks like this. And therefore, all the bowel at the end is basically like a bell clapper on the end of this artery, and it can twist. And if it twists, you can see there's the twist at the bottom here, and this is not good color. This is the color bowel is supposed to be. So it cuts off its own blood supply. It's a true surgical emergency. And it's treated by what's a Ladd's procedure, because Dr. Ladd's the one who described this. The volvulus, if the bowel is twisting, is always clockwise as you're looking to it. So as the surgeon, the first thing you do is twist it counterclockwise to detorse it. And we remember that because we're turning back the hands of time. Divide those Ladd bands. Make sure where it crossed the duodenum, it didn't keep the duodenum from developing so that the duodenum is patent. And then we're going to widen the base of the mesentery. And this is kind of hard concept to think of, but if this is all clasped together like this, if I can take a little pair of scissors or something and start dividing the things that are holding it into a fist and make it wider, this is actually much harder to flip than this is. So it decreases the risk that it'll have a new volvulus. And then we usually take out an appendectomy. I think that's getting to be a little more controversial, but that's part of it. So this is the final stage of fixation. And remember, we talked in another video about the pancreas, but the two sides of the colon are fixed to the retroperitoneum. You're fixed pretty much at the terminal ileum and the ligament of Treitz. What happens, what can go wrong in this third stage? Well, you can actually have an undescended cecum, so that instead of that last little bit of rotation that puts it down, it'll be up by the liver. An inverted cecum with a very long ascending colon, so it's like buckled back on itself. And lack of fixation of the duodenum and colon can happen. They're very rare. But basically, fixation is not that big of a problem. So hope that helps with malrotation, particularly, which is a devastating and kind of fascinating embryologic problem, and one that's so gratifying to fix if you catch it early enough, because you really, really have saved a life, which we don't get to do that often. So I really appreciate you listening, and feel free to email me and let me know if you have any questions.